Thank you. I'd like to welcome you. Heather and I would like to welcome you all to the Incarceration Prevention Reduction Task Force and Law and Justice Council meeting for April 21st, 2025. And before we begin, we'll start with our land acknowledgement. Jill, could you scroll the screen slightly? Thank you so much. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people, who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering truths at any and all public events. All right, let's call this meeting to order, and we will have a, let's see, we're going to review our schedule here. We're going to begin with the Ann Deacon Center for Hope topic. Then we will go to the STV Construction Justice Center owner representative presentation and go from there. Let's see, Marty, I believe you wanted to speak, or Holly and Marty, did you want to speak to the August meeting schedule?
You want us to do that right now?
Well,
we can.
You know what? We're going to lose a bunch of people halfway through this meeting. Okay. So if it's something that you want everybody to attend to, I would suggest we handle that first.
It was only a question about whether this group would like to have an August recess or meet right through the summer.
I would like to begin by saying I think we should take an August recess, as we've done, I believe, in the past. But I'd love to hear from anybody else who has an opinion on the matter.
I would agree.
Scott, yes, thank you. Anyone else? Okay, well. Oh, what was that?
I said I concur as well.
Thank you, Chief Mertzig.
Yeah, I concur as well. I'm pretty sure I will not be in town on that date.
I hope to be sailing in Canada myself, so it would be convenient for me, I'll tell you that much.
Shall we do it?
All right. Well, Marty, Holly, I think there's your answer.
Got it. Thank you.
Okay. All right. Very good. All right. Well, let's begin our conversation about the Ann Deacon Center for Hope. We have an update from Melora Christensen and Hannah Fisk. We are also joined by Robert Sullivan from Pioneer Human Services and Renee Reese from Compass Health. And please, let's begin with Melora, and then we'll have time for questions and such. We have plenty of time on the schedule for this part of our meeting today. So Melora.
Good morning, everyone. Melora Christensen, Health and Community Services, Response Systems Manager, and I am just going to hand this off to Hannah Fisk.
Good morning as well, Hannah Fisk, Health and Community Services. Is it okay if I share my screen?
Yeah, absolutely.
Can everyone see this okay? Yeah, okay. I'm really honored to introduce two remarkable leaders in our behavioral health community, Renee Reese and Rob Sullivan. Renee is the clinical nurse manager of the Crisis Triage Center, and Rob is the regional director of the residential services of our local detox center. They were the first agencies to operate services out of our new crisis stabilization center. With that pioneering role has come a great deal of community attention and scrutiny, and it has been truly a privilege to work alongside them. Renee and Rob approach feedback with curiosity and a genuine openness to understand, and they've continually adapted their programming to try to meet the evolving behavioral health needs of our community within their scope of practice. They're definitely experts in their fields, grounded in compassion and committed to high quality care. I'm so grateful they're here with us to share more about the important work that they're doing, as I could clearly not do it justice. So to start off with, Renee is going to speak a little bit more about her program, giving an update to go over 2024, kind of give you some information, maybe give you time to ask questions, and then Rob will take over. Here's their information if you ever want to reach out. I also pass this along to Jill, so it will also be available. Renee?
Renee, I
Renee.
can't hear you. Let's, could you test your sound?
Now?
There we go.
Okay,
Yeah, good.
thank you. My name is Renee. I am the clinical nurse manager for Triage. We are the mental health side of things at the Ann Deacon Center. So Rob, who will speak later, does the detox, and my focus is the mental health piece for the community. So I kind of wanted to go over a few things. Our scope of work, we are a 24/7, 365-day program. So we never close our doors. We're always available for admissions and for intakes from the community or walk-ups, which is a lot of people who come to our door. We are fully voluntary, except the little piece about law enforcement holds, which we did do one a few weeks ago. That went fabulous. So otherwise, we are voluntary, so people can come and go as they need to. They do not have to stay the 3 to 5 days, which is standard, but that is typically what people do with finishing the program. They stay that 3 to 5 days. We are a nonprofit, so we will bill insurance if that's available. If not, then it's not anything that's a requirement to be a part of our program. We are a crisis center, so the 3 to 5 day stay is very short for our clients, but it's kind of where we start the process. They're really motivated to make those changes in one way or another, and we're able to kind of start the process for implementing some care coordination pieces into the community. Hannah, if you can flip that. So we serve all the community partners in Bellingham who are mental health related. So we get a lot of referrals from the hospital, a lot of walk-ups. We get a lot of law enforcement, EMS, art team. We've had some referrals and walk-ups from them, as well as any of the other crisis centers. So Lifeline, also from our partners next door at Pioneer, we get people from them as well. I would say about 50% of our people are unhoused that we do serve at crisis treatment centers. So a big piece of that is looking for housing and setting them up for options when they leave. We do anybody with a mental health disorder or a crisis, and that is a self-defined crisis. So it doesn't have to be something that we approve as clinicians or medical staff. It's kind of what the client defines as a crisis. And we do only take people who are 18 and up into our services. Some of the things that would kind of be a deal breaker in admission, they have to be medically able to clear. So that would be vital signs, a breathalyzer, which they cannot be above 0.25, but Pioneer Detox can take them if they're above, and we would refer out. They cannot be withdrawing from alcohol. That's not anything, it's too medically acute for us to be able to handle on our side of things. They cannot be a level 3 sex offender. They cannot actively be verbally or physically assaultive. And the big piece of this is because it can affect the milieu and the other clients that are in there. We are a 16-bed unit, so it kind of becomes primary that everybody in the unit is going to be safe. Again, it's voluntary and they do have to have a mental health crisis. So there's not a ton that would exclude most people from coming in. The one we see the most would be vitals that are abnormal, and we would send to the hospital and have a medical clearance, and then they can be redirected back to us. So
Renee, would you like questions as we go, or would you like to finish your part of the presentation, ask for questions, or what's your preference?
maybe questions at the end, just so I can finish this.
Sure.
And so, yeah, if you, I love questions and I'd love to answer questions. So just write them down kind of as we go, and then we can tackle that if that works.
Wonderful. Thank you.
Okay. Yeah, you bet. So our staffing pattern at Triage, we do have our medical director, who is Shannon. I'm not sure if you guys have had the pleasure of meeting her, but she does join into some of these meetings. So she is over me, and then I am the clinical nurse manager. So I am the day-to-day one who manages the site. And I am a registered nurse. I also have a degree in healthcare administration, and I'm 6 months away from getting my psychiatric nurse practitioner license. So that's kind of where I'm at in my education. Under me, I have RNs who are always on site at Triage. We have medication nurses, and they are always on site. We have mental health techs, and they are always on site. They are very one-on-one with our clients who we bring into Triage. And then we have our administration team. They're the ones that the community chats with if they call in to do an intake, and they're do insurance and all that kind of fun stuff. So that's kind of how Triage is managed. So here are some utilized beds for the year of 2024. 75.1%. I think the goal is to be above 80, 85%. My real goal is 100%, but that's a massive goal, right? Which we want to have those goals. I started with Compass Health a year and a half ago of November. So I think with me coming in, there has been some changes that you'll see. And so this is kind of a breakdown that I give to my staff, because it's important for me to kind of see the growth pattern that we have and where we might need to learn some different ways to work things out. But as you can kind of see, this is broken down in different quarters throughout the year. So, you know, in 2023, we had a low percentage bed use rate. And then you can see in 2024, that bumped up. And you can definitely see in Q3 and Q4, we went from the 50s all the way up to the 80% of bed rate use days. So, and then you can see the yearly at the end. So this is for 23 and 24. We went from a 61% overall year use rate to up to 76%, which is a pretty good increase. This quarter that just ended, we're at 75%. So you can kind of see that we're still increasing those numbers. Individuals served, this is kind of the graph for that for 2024. So far for 2025, I will tell you, we have had a lot of unduplicated individuals, and we are seeing a lot of community people coming into our services having never seen them before, which is a good thing. So we're getting people who have mental health crisis, who either know about Triage or being referred by community partners like you guys. And they're showing up at our door to seek help. So it's a combination of stigma of mental health, right? It's a matter of creating a name for Triage and being a safe space for these people to come to, and people just knowing about us. And we're seeing a significant rate of unduplicated individuals, which is great. So referrals, this is the amount of referrals that we saw in 2024. So you can see a big part of our referral system is a self-referral. A lot of these come as walk-ups, and a lot of them will call and say, hey, I want to come in. Do you have any open beds? So that's about 50% of what we get. Other professional referrals we kind of talked about, they can be art team, community, different partners all over the place. Peace Health is another big one where we get a lot of our referrals. We have a system with them for an easier intake now. So that has kind of allowed for an easier intake process for them to continue doing their services while allowing us to get the information we need to have someone come into our center straight from there. We've been working really closely with the mental health court and doing some jail transfers, step downs to our unit. We've had several of those where we can restart the insurance for them and kind of get that process going while the first day that they're in triage and get that process going. And the goal for a lot of those clients are to get them into a position where we can stabilize them on medications to then go safely out into the community. In the jail system, they do not do long-acting injectables. So one of our goals is to, just in general, not just with jail transfers, to get clients who may be unhoused or are unable to go to a monthly appointment or take their medications daily, which is something we see regularly. Try to encourage them and start the process of an LAI, we call it, which is for schizophrenia, psychosis, those kind of clients. And they can last for a month, so there's no responsibility to take daily medication. So that is one of the pushes that we have started with our clients, and try to start that process while they're in triage with us. Law enforcement is also, sorry, Hannah, law enforcement is also a big piece of our referrals. And I know when I started, this was not very high, but we've continued to increase that. And actually this past month, we've had the highest amount of referrals that we have had from law enforcement. So it is continuing to get better. We have implemented a 5-minute or less intake process for everybody, but law enforcement can just drop and go. So that I think that has really helped. Okay, you can move on. This graph, you can see that 937 of the people that were with us for 2024 completed their stay. This means they came in with a mental health crisis and they're leaving stating that their mental health crisis has finished. They feel confident going back into the community. They no longer feel suicidal. They no longer feel psychotic. They no longer feel like they want to harm anybody else or could be a harm to others. So that's a pretty significant number. And it's nice to see that we're releasing people back into the community, having completed their 3 to 5 day stay, with the majority of them now connected to community support beyond what we can offer. We did have 215 who withdrew from services. A lot of that is if they didn't want to come in through the 24-hour process overnight when they called us, they may plan to come in the morning and then feel better in the morning. So it's those kinds of situations that you'll see that in. So changes to the programming in the last year since I came into triage, we have increased our admissions by 15% that we showed on that graph. We've implemented more client-friendly focuses. Those of you who have spent time with me know that I am really passionate about humanity in general and allowing clients that come into triage to feel like they still have choices while they're there. In a context of making healthy ones with supervision. So we have done things like simple, but that contribute to great quality of life in triage and trust. We've opened up a snack bar. So we have a snack bar. They're hungry. They don't have to ask us for food. They don't have to wait for a meal. They can make their own sandwiches. They can make some ramen. We have regular coffee now and not just decaffeinated. Just a lot of those humanity things that kind of play an important role when you're in crisis and looking for support. We've created reading corners. We have activities like yoga. We created a garden in the back. So currently we have these beautiful flowers blooming. And we also have tomatoes growing and cucumbers, and our clients are a part of that. So they do the watering. They can eat off of those fruits and veggies as they ripen up. They also help us plant them. So they become a part of that. Nature is a really big thing for healing and crisis centers. So a lot of outdoor sun activities when it's available. We do walks around the building. We also allow smoking now. We only had smoking times, and we found that a lot of people would leave because our smoking policy was too tight. And I really wanted to decrease barriers in triage. So we did implement that they can smoke at any time. It is supervised with cameras, but they do have access to that outdoor space all the time now. The door is not locked and they don't have to be let out by somebody. Other things that have changed, the medical clearance time of less than 5 minutes, really important. And that is a big process that did change. And then the overall intake process, they speak with the clinician, they speak and do a nursing assessment to make sure they're healthy. And if there's anything we need to treat, we also have FNP. So like we had somebody with scabies, so we can start that process while they're in with us of getting that cleared up, or lice or wounds, all that kind of stuff. We have created a lot of outside connections, contacts for easy referral process for our community partners. It's a shorter process that they can do over the phone with our admin staff. And like I said, we focused on humanizing mental health care clients and giving compassionate care. And we did open the lobby. So for those of you that were wondering, when COVID happened, everything was kind of shut down and we just used the back doors. We have opened the front lobby and it is staffed fully with one of our employees from 8 to 4 o'clock. So anybody can walk in to seek help, and we will get them to where they need to go. And that's for Pioneer or our side. And cops can drop off there. Anybody can walk in. It's been a beautiful thing. It's lovely. So that was a big piece of something we did do this year. Some of the challenges we have, and we're really trying to work through this and would love to communicate this further outside of this setting because it is such a desire that we have, is housing. As you guys, I'm sure know, there's not enough for what we're needing. A lot of our clients and a lot of our staff are really struggling with only having these people who are super motivated while they're there for the 3 to 5 days. And then we're maybe sending them back to their car or Lighthouse Mission, which is great. But if they can't go back there, they're going back to the streets and the process starts again, which is really unfortunate. So this is a big piece that is missing for us, and having something that maybe is a 1 week to 4 weeks, in between, that then can have even longer amount of time to set up more services for these clients so we don't get them back the next day. The shortness of the program leading to decreased support after an exit, stigma of mental health disorders. You guys all are very aware of this, being who you are. I think that the community is coming around, but I still think it's work that needs to be done. And it's also work that needs to be done with our clients seeking services because they're nervous coming in and admitting that they do have something that they need help with. And then wraparound services, just in general, we have created a lot of community partners and have been using them, but just the time frame of it, with us being a 24/7 facility and most other places being a Monday through Friday 8 to 5, it kind of puts a little bit of a damper on those who are trying to get support through the weekend. So we do what we can on our end, but we can't reach out to anybody. We can't set up insurance. We can't talk to housing. We can't do any of that. So that would be another challenge that we have. Some focuses that we have, all of our staff is going to be going and participating in a trauma training for all of our staff. So as you guys know, we have clients with mental health conditions who also have substance use disorder, who also have extreme trauma, whether it's PTSD trauma of something that, recently happened, or if it's childhood trauma. So those are things that we are training our staff in on how to react in a trauma-focused way to those clients who may come in elevated, and how to calmly decrease that and listen to their needs. Including more family-oriented options. So we do have space and availability for families to come and see our clients while they're there, and we actually encourage it. It's very important to us. We have a lot of moms or other family members who have kids that want to see them, so we have a space for that to happen, and we're going to continue to increase that. Community partner relationships, we're working on continuing those and even creating more. And then care coordination, this one's really exciting for us. We're getting ready to implement a care coordination position just for triage. So we have one person who can focus on all of the things that our clients that are in our care need. So the goal is one person can reach out to all the community partners, make those connections, and be the point for our client in triage and start setting up all of those things that are necessary at that time. So we're excited about that one. Okay, any questions for me before we move over to Rob? Yeah.
Rebecca, Chief Mertzig.
Thank you and apologies. I'm on the road. Just wanted to say thank you so much for addressing some of the concerns of law enforcement. I think having that ability to drop off quickly and move on to the next emergency call has been super helpful. And I think we'll probably see numbers continue to rise because word will get out. If someone has a bad experience one time, then they're not likely to use it as a resource later. So just want to express some thanks and gratitude for that. I also I'm curious. So with us seeing more new faces, I'm wondering if there's any sort of data collected about where people are from.
That is
I'm
something
wondering
we,
if
yeah.
these are folks that are, yeah, go ahead.
Yeah, so that is something we're collecting in a profile kind of way, but we haven't started tracking them for triage, which we can do. I can tell you a lot of them are from other country or counties inside of Washington. And we are getting a lot of the LGBTQI community, and we are seeing a lot of trans people admitting into our clinic who are from other states coming to Washington because they feel as if it's a safer state for them to be in. So we are getting a lot of, particularly those clients who are coming to Washington to find that kind of connection and going through the crisis process, and we're able to set them up with resources and connect them for that piece. So it's kind of, it really is a mix, but I would say we're seeing a lot of younger people, family people who are hearing about us and know that they need help within our own community. I would say that's the biggest piece of people we are seeing new into triage, along with the others, but local people is more of who we're seeing as a new person.
Gotcha. Well, it's kind of very cool actually that people view us as safe and welcoming. But I'm also like, well, are we looking into, if someone's support system is somewhere else, specifically for substance use, not as much the other things. If their support system is elsewhere, are we working towards, are there options for folks to get back home where their support is if from leaving triage, or is that another entity that would handle that?
Yeah. Yeah, 100%. We do focus on getting them back to where their supports are. A lot of clients that actually come in to see us feel like they don't have a lot of support. So they may be looking for a community to support while they're here. Some of them do go back home. We can also provide housing or send them off to a longer term rehab. And most of them are open to kind of going to wherever has open beds that can help with what they need, whether that's substance use detox and long-term rehab or mental health, like adult family living down south. So that's kind of a hard question to answer because a lot of them coming in don't feel like they have support, but if they do, we definitely make sure that they have visits while they're there. We do have phones on the unit that they can use at any time, and we also take calls from any of their support system, and we really encourage those because that's a big motivation for them being there, and that's one of the big things that's going to help them once they leave.
So thank you.
You bet.
All right, thanks for that. And Scott.
Yeah, a couple questions. You had a slide on utilization, 75% fourth quarter last year, or sorry, 84% fourth quarter last year, and then dropped to 75%. Are there barriers to getting in, or why would you see such a drop when you were higher?
I guess, Hannah, is there a slide that shows that? Because I'm interested in.
I was trying to, is it the one before? Is it?
No, it's that
Yeah.
slide there. It's
It's this one?
84% in the fourth quarter of 24, and it dropped to 75% in the first quarter of 25.
Oh, I see what you're saying. Yeah, so
Oh.
our triage kind of fluctuates based on weather is one of them, based on resources that are available to the community at the time. Those are like kind of the big motivating factors. You can kind of see that were in that 70% range during the first quarter. I don't know that I have a real honest answer for you as to why that is. I don't know if Hannah and Laura have anything that they can add to that based on the trends that they've seen since they've been here a little bit longer. But looking at quarter one, I see the growth of that from the 23, 24, 25, and I'm hoping that that continues, and I'm hoping that we do stay up in that 84%, range and even higher. So that's.
And I guess what do you do? Is there anything you're doing to encourage people, or are there barriers you're taking down to get more people to come in?
Yeah, I mean, all of the things that we've implemented, the smoking policy was a big one. Allowing them to get phones and emails, phone numbers and emails off of their phone while they're with us, but still having them safely put away, having them have access to phone calls. We also welcome and really encourage other community partners to come in and visit with our clients. And so that's happening a lot. Every day, I would say we either have the hot team there or the cores team or PAC team or case manager from Lake Whatcom. All of those things are happening behind the scenes. And so that's something that's really beneficial and a decrease in barriers. So they're continuing, if they're already assigned case managers and outpatient services, they're continuing to receive those. And a lot of times actually reconnect with those that they haven't been connected to because they've kind of been off the grid once they leave. So.
And then you talked about outcomes and then people leave after 3 to 5 days. Do you have data on how effective the outcome is, I guess, in terms of what percent come back after 3 to 5 days?
Yeah, so that definitely varies. I can get that information for you. I can have them pull that off of our charting because we do track that. I would say that there's definitely a core client who comes back. I mean, sometimes we have clients come back once a week. So if they're at baseline, we encourage them to connect with their case managers that they have, if they have those, and their support systems, because we want to have, room for other people. Or we've done all that we can do. They're taking their medication. They've seen our provider. They're in outpatient services. But it's not very often that we would deny somebody for that piece of it. And then other times we just admitted someone who we haven't seen for a year and a half and, started having a new mental health crisis, and he's getting ready to leave today. So that is just something that's really kind of all over the place too, Scott. I don't have like the best answer, but I can get some data to kind of give you a more clear answer on that.
Well, we're always looking, Peter and I in a way, are always looking for good data on all of this stuff.
We have the ability to pull it, so I can do that.
That'd be great. And then finally, staffing. Are you fully staffed? Can you find people, or are you short staffed, or where are you at on staffing? Because I know that'll be an issue someday.
Yeah. So our staffing is wonderful right now. We are missing a clinician. We do have one during Monday, Tuesday, Wednesday, but we do need a clinician for Thursday and Fridays. But also the RNs can also do the role of the clinician. So we don't have a hole or a barrier for people coming in because the RN can do that role. It just becomes a lot of work if we're doing a lot of intakes in that process. So the clinician is responsible for doing the mental health assessment, and that has to be done within 3 hours of an admission. So that's kind of the role we're looking at and have been trying to get a clinician to. That's the biggest one. The care coordinator can also help with some of those services. So our staff is lovely. We have such a great cohesive team. We are staffed well. And yeah, I don't see that as an issue, especially having gone through all of our union negotiations that you guys may have seen. So now we have people accepting positions quite easily now, which I'm really excited for.
And what is totally staffed? What is the number?
So I have 52 employees. I have the largest group of employees, and that would include a nurse 24/7, a medication. Yeah, you can go back to that slide. So a nurse 24/7 for admissions. The clinician are day shifts, And then our LPNs are 7 days a week as well for medication management. And we just have one of those. So one RN, one LPN. Our MHTs during the day, we have 4 of those for a 16-bed unit. In our admin support, we have our front lobby. We have our admin support in the back that does the main intake piece. And we also have our admin manager. And we also have our psychiatric nurse practitioner who is there with us daily and sees clients daily for us as well.
So when
go
you
ahead.
say 52, is that full-time or part-time or?
It's kind of a combination of both. It's either full-time or part-time, but most of our staff is full-time. They work 312s. And that's kind of how that process works. And then night has the same. We do have 2 MHTs on night staff, so it kind of gets cut in half for the MHTs because most clients are sleeping or don't need quite as much support.
Great, thank you.
You bet.
Thanks for those questions. Scott, Raylene?
Thank you. I really appreciate some of the barriers that have been decreased that Rebecca, Chief Bartsick, was discussing. My question is, I see that you had it broken down by EMS, lead, and law enforcement in the other slide of who's using it, the referrals. My question is, on the law enforcement referrals and EMS, are you seeing them generally from the Bellingham area? Or are you seeing them throughout the county? Are there barriers for individuals that are further outside of the area not being able to get there or be transported to be able to utilize the services?
There are no barriers for outside of Whatcom County to come and use our services, or even outside of Bellingham. We see them from the sheriff's office, from local law enforcement. We see them coming from everywhere, and the same situation applies. They can drop and go. So the biggest thing that I would encourage those with law enforcement and working with them, the hardest part is having someone who may be verbally or physically aggressive. Like, those clients are just ones that need to be rerouted to the hospital, and then we can take them from there. But everybody else, even if they don't pass the medical clearance, my staff, we've implemented that they are not to call law enforcement back and have them come pick them up. It is our job, once they've been dropped with us, to then find the ride to the hospital, which we can provide for them, or to other resources that are necessary. So we see them from everywhere. It is a very short process. We do have access to taxis, and the county was helping with that as well. We are supplied with bus passes, so we can get our clients on a bus to come and see us if necessary, or that's something that we have a little bit of a fund for, to pay to get them to us if necessary. And we do have people that use that down like in Skagit, Mount Vernon area. We pay for that, or if they even come from the islands, we have a way to make that happen too.
Thank you.
Yeah.
Very good. Alexis?
Hi there, Renee. Not so much a question, but just kind of support in the data that Scott was inquiring about from Q4 to Q1 in the following year. We also see a dip in our numbers as well, I think, especially as we approach closer to spring. So it's likely a weather thing, and as we're, kind of thawing out from maybe seasonal depression and some other conditions that are a little bit more weather temperament. So thanks for showing that data. It's really helpful. Appreciate it.
Yeah, of course. Thank you.
Great. Any other questions for Renee before we move on to the next presentation? Sheriff Tanksley, do you have any information for us on your utilization, the Sheriff's Department utilization, or comments?
Sure. So I have Chief Deputy Gum on the call this morning, and he was going to give his take from the Sheriff's Office perspective. Thank you.
Deputy Gum, feel free to go ahead. Are you there? All right, well, we can return back to you, so Robert Sullivan, would you please go ahead and give us your presentation on the Pioneer half of the equation?
Sure, thank you very much. Rob Sullivan from Pioneer Human Services. I want to thank Renee for letting me follow her, and thank you for having me at the IPRTF. So Wacom Detox is licensed as a voluntary residential treatment facility for acute withdrawal management services. And that really what that means is that our admission criteria is people 18 and over who are either currently intoxicated or impaired by substances or in withdrawal management, needing withdrawal management services and willing to come in for services. Sorry, I lost my thing there. We started working on trauma-informed care in 2024. And it's really been an ongoing process. I think at times we make a lot of progress on it, and then staff sort of drift and forget what we're working on. So it's a constant training and retraining, trying to create the most supportive environment that we can and avoid re-traumatizing people. We do provide a clean and safe environment for recovery from intoxication and withdrawal, as I said. We provide counseling and motivational programming, so we do individual and group counseling every day, assuming the person is stable and not impaired, or not sick enough that they're not able to participate. The goal of our program is to move people into further services for treatment. And from the time that a person enters into our program, we're looking at aftercare and discharge planning, trying to create a discharge plan that's going to meet their needs. That includes supported housing, outpatient, inpatient referrals, trying to connect them with community resources, either new community resources or community services that they were connected to. We try to encourage developing support and peer networks. And then we do medical and care coordination for referrals who are with us, who need ongoing medical care beyond us. Average length of stay, as Renee had mentioned, is 3 to 5 days. And that's really dictated more by what insurance companies are willing to pay and a person's need to be in services. We do phone screenings other than law enforcement and EMS drop-offs to make sure the person's stable enough to be with us. We have the reasons that we would decline somebody is somebody who needs oxygen. We're not able to facilitate that. Somebody who's above our level of care needing a higher level of care. Somebody who's over 24 weeks pregnant. Somebody who doesn't have a substance abuse disorder, meaning they haven't used any substances within the last 4 or 5 days and are not exhibiting any withdrawal management services. They need to be able, if you're not able to take care of your activities of daily living, meaning incontinence, feeding yourself, bathing yourself, those kind of things. Those are things that really are above our level of care and need one-on-one care. And then the biggest hurdle we've had in more recent months is benzodiazepine use has increased in the community, and quite a bit of it is illicit. And because we're not, that kind of detox is one, both dangerous, but also very time consuming. Some people can be in a hospital for long periods of time. That's not something we're able to manage. Excuse me. If somebody's threatening or abusive, it's not the program for them at that time. It doesn't mean we won't consider them later, but it may not be our time at that moment. And then we always look at safety for the client and safety for staff. I would say some of the next slide, I'm sorry, Hannah, I forgot about that. So I'm the director of the program. I work with the medical director and our director of nursing to make sure that we're adhering to the policies we've designed. Underneath me is a nursing supervisor, a subclinical manager, a health and resource manager, and we have 6 RNs, 9 health coordinators, and 6 substance abuse counselors. That covers us 24/7 with an ARNP on call 24/7 as well. And the next slide. So our utilization has really gone up and down. I think some of it is weather dependent and where people are at. And I think some of it at times is just the staffing that we have at the moment of not being able to manage the number of intakes that want to come in due to having an intake for us takes about 2 hours, and that includes medical clearance. And so there's not any way for us to be as efficient as Compass is at this point. That is something we're looking at this year and have several meetings set up in the next couple of days to discuss that. So, and if you'd go to the next one. As you can see, our numbers of unduplicated folks is pretty low. And by that, I mean, we have a lot of people who will come to us, may go into services with somebody else, may not go into services with somebody else, and return to us because they've started using substances again. I think that's in part due to some of what Renee had talked about with lack of housing. It's also lack of resources for inpatient treatment or having a safe, stable place to live with support in the community. Hannah, there you go. Most of our referrals, quite frankly, are self. We get a fair number from Peace Health and then other agencies, but the majority of our folks are self-referrals. We have sent, for 2024, we had 774 people complete. We had 805 people withdraw from services. And what we saw a lot with that, and we've really struggled this year with, is fentanyl. Historically, withdrawal with fentanyl with opiates was very straightforward. With the advent of fentanyl, it's really changed. And we worked pretty closely with Dr. Bosted at the health department to try to look at what our protocol is, what adjustments we can make. And I think we've seen some success with that in the last couple of months, but it's definitely been a struggle this year. The changes we made in 2024 were admitting pregnant women who are pregnant 24 weeks or less. We continued to work on implementing trauma-informed care, and we embedded supported housing and a peer bridger into our program. And this year, we just started a peer bridger program, actually this morning, to try to take people who have been in our programs and connect them with services in the community. And instead of making it, we use the term warm handoff, but really trying to take that person from us to that next connection and make sure they stay engaged with it to the best of our ability, to really try to wrap around those services. The challenges we've had is really the lack of the ability to handle people who need continuous medical monitoring and advanced self-care assistance. It's been a challenge. As people in substance use and behavioral health, as their needs increase, it really limits the ability at times for us to help them as much as we'd like to. We've also seen that with people who are needing higher levels of care than what we can provide. And as I mentioned earlier, the benzodiazepine withdrawal is not something that we can handle at this time. Our focus for this year is really reducing our roadblocks and barriers, whether we create them or they're created outside of us, increasing our use of trauma-informed care. As I mentioned, we started a peer bridger program this morning, increasing community awareness of services and expanding the relationships with providers, both locally and folks who may be coming from other areas of the state. And then any questions for me?
Dan Hamill, please go ahead.
Yeah, good morning. Thanks for the presentation. My question is for your Bridger program and extended services for folks once they just discharge out of your program. Just a short distance away from your facility is the mobile medical units from Dijwalik. And they can provide methadone and Suboxone on board their units. I'm just wondering, to what extent is your plan to work with them?
We've actually been referring people back and forth. And we had multiple conversations before they came down and started those service because it is a natural fit for us. They're going to get people who need withdrawal management services, and we need people to get connected with continuing care services. And we've worked fairly closely with them prior to them coming down. We've been taking referrals from them and for Island County for quite some time.
Thank you.
Thanks, Dan.
Alexis, go ahead.
Hi there, Rob. Thanks for the presentation as well. Quick question about benzo use. I know that we've worked with a few clients who weren't necessarily aware that what they were using had trace amounts of benzodiazepines in it, et cetera, due to cross-contamination. So the question I had was, if someone is working to admit to detox, they do the initial UA and that's found to be in their system, is there any transportation provided to connect them to a medical detox that would be more appropriate?
At this point, we haven't done that with the Peer Bridger program. We will be able to do that.
Okay.
I think the challenge at times is finding a medical detox program that will take them. We typically use Fairfax and Swedish. Both are relatively full most of the time, so it's certainly a challenge.
What about Evergreen Recovery Center's detox? How's that?
Evergreen Recovery, we've used a time or two. They have historically had challenges with admissions. I met with their chief operating officer within the last couple of months, and they're working on reducing those roadblocks for them and increase the number of people they can take. But similar to us, they operate very similarly because they're not a hospital-based program per se. There's limitations to what they can do.
Sure. Okay. Thanks for that info.
Thanks.
Heather, go ahead.
Good morning, Heather Flaherty. I'm here as a citizen, and I am wondering about, can you go back to the slide that showed it was around 900 or so that self-referred to detox? Is that right?
1,679.
Okay, 1,600 self, family, and other referral. So that is the most significant referrals.
Mm-hmm.
And then can you go, oh, go ahead, sorry.
No.
And Peace Health and all other professional referrals are the next two.
Yeah. So all other would be any community services that don't fit in one of those categories.
Okay. And can you go to the next slide one more time? And so 805 withdraw from referral.
Mm-hmm.
That's the highest.
That's by far our highest number, yeah. As I mentioned, fentanyl has really changed detox. Opiate withdrawal up until fentanyl was, I'm not saying it's not dangerous or risky, but we really kind of had those pieces down. We knew what you needed. We knew what would manage your symptoms. We knew how to manage your symptoms. When fentanyl came in, it really changed that, because what we're finding is people who with just straight opiates would typically go into withdrawal within 24 hours. We're seeing people in fentanyl within withdrawal within 3 or 4 hours. And they are often mixed with other substances, things we don't even know that are in there. And so what we've started to have to do is what we call macro dosing. So when somebody comes in, whereas normally you would do Suboxone at 8 hours, at say 2 to 4 milligrams, what we're having to do is macro dose people and get them up to 24, 26 milligrams of Suboxone right off the beginning. And try to titrate them down. I think we've seen a better success with that in the last couple of months. But it was a challenge for us in 2024. Fentanyl has changed things in a very drastic way.
And I'm sorry if you already shared this. Do you have the data around how many are non-duplicated visits, or how many unique individuals are coming?
Oh, we do. Give me 1 second. That's a great question.
While you're looking, my next question too, that some others on the team here might also be able to help with. One thing I've been deep in is hearing from people who have experienced the involuntary treatment services. And my understanding is that this is not set up to do involuntary holds. It is.
We are not. We are strictly voluntary. And to answer your question, Heather, we
Yeah.
had 795 people last year who were unduplicated, meaning they came and saw us one time and did not come back for the year.
Do you have the data around how many people come back? How many repeat visitors you have?
Sure can. I got to do a little bit of math,
Okay.
which requires a calculator just for accuracy. So out of that, we had 1,104 admissions. And out of that, 795 were not duplicated, were unduplicated. So we had 304. Is that right? 309 people come
Yeah.
back to us.
Okay.
More
Thank
than-
you.
You're welcome.
Oh, sorry,
Sorry,
go ahead.
one last one. I am under the impression that this facility could not transition to being a secure withdrawal management.
This facility is actually built so it could be secure.
Okay.
It would require staffing changes. It would require funding changes. And so it's not something we've looked at, or at this point, something that Pioneer is interested in doing.
Yeah. Thank you.
Scott, I see you there and want to get to you, but I do want to give Chief Gum, and now that he's been upgraded to a panelist, an opportunity to speak. If you'd like to.
My question will be real quick, I think. I'm just a little confused
Yeah,
at this
go
point.
ahead.
This slide that's showing adds up to 2,307 people, but you just said 1,104 people were admitted. I don't understand the difference.
That
Are
is a
people?
good question.
What's that?
I may not have counted everybody.
Okay, so but maybe you could just send the data out then when you
Sure.
get it. That would be helpful. Thank you.
Mhm.
All right, Chief Gum, are you able to speak to us?
How's my volume?
You're perfect.
Okay. I'll keep it brief for the sheriff's office. The centers, it's been a work in progress for quite a while now. But I will say their primary focus is openness to change. And that's what's made things continue to develop, continue to grow, and continue to work. Anytime we have a hurdle or a barrier, we get together monthly for the oversight committee, and that's all about change. Everybody there is open to constructive criticism or feedback, and they followed up with a lot of just responsiveness. They provided our deputies with in-call referral cards, one side for mental health, one for triage, take the guesswork out of what we need to do. And they furthered up with, we can just bring somebody in and they're going to figure it out. Don't make our deputies do the evaluation. So that is what we've really appreciated as it's continued, month to month, year to year, is just they're open to our needs as first responders. You'll see we're not the highest utilizer, a lot of self-referrals. One thing I don't know if they track is when our deputies go to scenes, behavioral health deputies, to avoid stigma and more traumatization, is getting the partners, the families, the parents to drive the people into the center themselves. So I don't know how we track, law enforcement's assistance in getting people in there on their own, but it's been a good year. We just used our first involuntary 12-hour hold for the first time ever, I think 2 weeks ago. And the deputy reached out and said it was seamless. So every probably 6 weeks, I sent an email countywide to all the deputies saying, I'm looking for any problems, any issues you had with the center, either side, let me know so we can fix them. I didn't have any negative responses on this last request. And I just had a couple of the positive, how much smoother it is. So we appreciate the partnership. I think I meet with Amelia on Wednesday, again, just to sit down and touch base and further relationships. So it's been going very well. We appreciate everything they're doing out there. They're making it much easier for us.
Well, that's great to hear. A little over a year ago at the Joint Behavioral Health and Legal and Justice Committee, we had a similar presentation, and things at that time were not going quite as well as they are now. It sounds like
They're
there's been a
very
lot
responsive to input and change, and that's what makes it work for us. There's no excuses. There's no, well, we'll see what we can do. They've just made the changes. They're very accommodating to law enforcement, EMS, our community paramedics. Although, you know, we're not their highest utilizers, they're incredibly responsive to us. So it's been good, been real good.
very good. Chief Mertzig.
Can we, I'm just, I have a question about involuntary holds. I know that we've used that term in different ways, and that's not set up to be an involuntarily facility. So I guess my question is, does that mean the same thing to me as it does to you guys in terms of like someone comes on in a law enforcement involuntary 12-hour hold, but they decide in 6 hours they want to go? What happens to them?
Do you want me to speak from my side over at Triage?
Sure.
Yeah, so we do have an involuntary license to hold, and we have staff who are trained to do so. So we also have the ability with a seclusion room and a seclusion bathroom. We 100% can do the 12-hour holds, and they are required to stay with us for those 12 hours. We are not required to let them go. The rest of our stuff is voluntary, but a 12-hour hold is not. So the goal with 12-hour holds on our side is to work through the process with them and try to get them to then voluntarily admit after that 12-hour hold is complete, to get them services that will be longer lasting than what they're coming in for. So that's kind of the goal. Now, it's not always work out that way, of course, but we are able to do so. And Hannah might have more to say about this because she and I just discussed this recently. But the 12-hour holds are 100% a go. We have capability, we have the licensing, we have the staff to do so.
Okay, and that includes a physical intervention if necessary.
Yes.
Okay, I think that's a pretty significant change. So that might be something we.
Yeah.
Okay.
We won't use restraints, but we would get them into the seclusion room and that's where they would stay if it got that bad. Our last person was able to be on the floor with everybody else, and that's kind of the goal.
Right. Okay. Thank you.
Yeah.
Chief Mertzig, just for clarity, for the withdrawal management piece, we cannot do involuntary.
Yeah, I understood that. Yeah,
Okay.
thank you.
Okay, yeah.
I've got a question for either Hannah Fisk or Melora. Would you remind us all about the funding for the Ann Deacon Center for Hope? How does that work?
Yeah, we subsidize, I mean, for these programmings, Compass and Pioneer operate their own programs. So we don't pay or contribute to any of their operating costs. These agencies have taken that burden on them on their own. We do a monthly rent amount to cover the basic maintenance of the facility. So that's really all it covers. It's $2,000 for each side to support just the upkeep. And those are out for RFP right now for the next cycle.
And then Renee and Robert, would you speak to just give us all an idea of how your funding works?
I can go first. So for Wacom Detox, we have really three primary funders. We have MCOs, so all Apple Health with the 5 mental MCOs. We have funding through the North Sound ASO Administrative Services Office for folks who are not insured or are on Medicare, because Medicare doesn't have a defined benefit for withdrawal management. And then we have, we have some private insurance, and then we have the Division of Behavioral Health and Recovery has money set aside for folks who are Alaska Natives or American Indians, and are not covered by any of the other providers.
Great, thank you. Renee?
Yeah, it's the same on our end. Basically, We have people who are under the private insurance MCOs that we are able to bill. And then the state funding, the NSBHO, is the rest of that piece, which is how we're able to take clients. They don't always pay, so it comes out of Compass being a nonprofit. And that's just kind of how that piece works. So.
Okay. Well, thank you very much, everybody, for this presentation. Very helpful. It was a great update, and really appreciate all the good work that you're doing.
I did want to say before leaving, if anybody wants to come and visit Triage Side, you guys are more than welcome to come and sit with me and chat, and I can take you on a tour or whatever that looks like. Just come see the space and how it works and talk to staff and talk to me. So I just wanted to extend that to you guys. So.
And we would happily do the same on the Pioneer side.
Very good. Thank you so much to Pioneer and to Compass for doing the good work here in Whatcom County. We all appreciate it. Now on to STV. Ashley, are you going to be both presenting, or do you want to share your screen?
Sure. Yep, I can share my screen. Hold on just one second.
Right.
And make sure, there we go. So many buttons. All right. Sorry, I'm struggling with share screen.
And Ashley and Adam, while you have made many presentations to us already in various groups, this is a whole different group. So if you would begin with a little synopsis of who you are and what you're up to.
Absolutely. Can you see it looks like runners at the start gate?
Yes, I do.
Okay, great. So we'll jump right in to tell you who we are. So again, STV, I'm sure some of you have heard about us. I know that we've met with various pieces of different, I know there's a lot of overlapping participation in these groups that we've met with. So to your point, Peter, we will kind of start from scratch. So forgive me for those of you who have heard some of this before. I'm Ashley McLaren. I work with STV. You will be meeting Adam Johnson momentarily. Russ Isley, y'all will get to know very well at some point. Also, we are your consultant core team to get the products. We're the basically owner's rep is kind of the term that we use because we are here on behalf of Whatcom County to make sure that this project gets executed well. We're in the first phase right now. We've been on board for about not quite 3 months. And in that time, we've really been focusing on setting up the project, and we'll talk to you a little bit about that. But so I am really in charge of communications and strategic management, kind of ensuring that the framework is in place to move the project forward smoothly. That's a framework that, we start from the beginning, but it will develop. It's kind of a living, breathing thing is this project. And so we will continue to develop and monitor as we move forward. Adam is more of a tactical leader. He's responsible for moving the day-to-day work forward. So he's like really down on the logistics, making things happen. And Russ will support the team early on, getting processes in place, but then also be the boots on the ground and responsible for progress once we break ground. We're backed by additional resources, a team of experts beyond the core team that we will bring in kind of strategically at various times to support the designers, the construction team. So there's lots of different experts here that work both in justice operations and also behavioral health and well-being. So that will come together to support as we start to develop the real program and really get the project underway. So as I said, we're in the first phase. These are our primary objectives, our scope of work right now. We've been, again, on board, not quite 3 months, and we've really been focused on getting the kind of foundation started. So we want to support informed decisions. One of the biggest risks to project schedule is with a group like this and have so many different stakeholders and making sure that they're all adequately informed is to get the team organized and to develop a communication plan. That's underway right now. We'll talk to you about where we are in that in the schedule in a second. because we really want active stakeholder engagement. We want everyone to be informed. We want to have adequate feedback loops. What we don't want to do is get too far down any of these paths that we're about to go down, and then someone says, wait, I had never heard that before. That would be a big failure for us. And so that is the number one thing that we find most important. That's for me, this like my spidey senses go up when I come on a project that has this many people involved. So again, supporting informed decisions to drive project success. So we need to define scope. We're in that process right now. We are establishing the schedule. We're going to manage it moving forward. We're establishing the budget, and we will manage that moving forward. And then we're building the team. So we are in procurement right now. We developed the strategy for construction delivery, which is progressive design build. You'll hear us talk a lot about that. And we prepared in order to do alternative delivery. So anything besides design, bid, and build, you have to go to the project review committee. If you are a public entity in Washington State, we prepared that application, we presented to them, and we were approved in late March of that construction delivery. And now we are procuring the design and the design builder. So it's the designer and the contractor that come together at one time. And we'll show you where we are in that schedule also. But this is really the kind of just beginning the foundation. I know it seems like you've probably heard about us for a while. It seems like we've been around a while, but in the first 3 months, we've gotten a lot of work done. And we've also been kind of understanding all of the work that you have done. I mean, this group, among others, there's just a wealth of knowledge that we've been able to kind of download and synthesize, and we're really excited about that. We want to make sure that we're executing on that moving forward. And so with that, Adam will tell you a little bit more about that's kind of where we have been. Now we'll talk about next steps and milestones.
Yeah, thank you, Ashley. Yeah, so I'm Adam. So in the gray, you kind of see what we've been doing for the past 2 months. We got brought on February 2nd by the facilities management team. And it is in the execs department. That's where we got contracted. We had a mad dash to get our application into that project review committee. That's a state board that approves our use of progressive design build. And for those that don't know what we're talking about, when we talk about progressive design build, that's a process we use to select a contractor based on qualifications instead of just the lowest bid. That's the 50,000 foot level version. I could talk about it for like 2 hours, but we don't have time to do that today. So, and I could totally nerd out on that, but they won't let me. So, but yeah, basically we're selecting a design build. So both the contractor and the designer at the same time. They're one team based on qualifications. There's also a price component. To do that, you have to go to the PRC, submit an application. We did that. We got our approval in March. We've been working to develop the RFQ. That RFQ dropped last week. So you could go to Whatcom County's purchasing portal if you want to see how our first stage and how we're selecting that design build entity. That dropped on Wednesday of last week. Again, that's the first stage. We'll use that RFQ to shortlist 3 firms, but that is where we're at in that process right now. Down on the bottom, you can see we started that communications plan. That's really what Ashley's been doing. We've been having a lot of different stakeholder meetings in the meantime. That's what those little blue dots represent. Back in March, April, so excuse me, March 31st, April 1st, we had our jail capacity kickoff meetings. Back on that big org chart, one of the people listed there was Eric Ratz with DLZ. He's a sub-consultant of ours. I think a lot of people have probably heard about the Franklin County project. That's a justice project that was completed in Columbus, Ohio. That's Franklin County, Ohio. He was the lead architect on that project. We brought him in. He's a sub-consultant to us. He started the jail capacity analysis. So we did 2 full days of meetings. I had a lot of the jail staff there. Sheriff was there. Undersheriff was there. Caleb Erickson was there. Hannah Fisk was there. We had staff from facilities there on day 1, really talking about what the current state of affairs is. We did a tour of the downtown jail. We did a tour of the work release facility there. And then day 2, we also had the prosecuting attorney and the public defender there talking about future state and operations, and then also presented a list to the jail staff of about 30 different pieces of data that would be needed in order to complete that jail capacity analysis. So at the end of this call, I'm sorry, we're not going to have a bed count for you or anything like that. That's being worked on right now. And we'll see towards the end of the schedule what that's going to look like. But that process is ongoing right now. And then May 5th is when we're really going to start on the behavioral healthcare and Medicaid feasibility studies. That process has kind of started, and we're going to get started on that really in earnest in May. Kind of continuing along that bottom path there, we're going to have our communications plan complete, I think the week of May 9th or so, but middle of May, we're going to have our communications plan complete. Ashley may talk a little bit more about that. And then back up on the top, we're going to continue our selection of that design build team. So we'll use that RFQ. We'll receive statements of qualifications from those teams, and we'll shortlist down to 3 teams. And then we'll issue those folks an RFP. So we'll use that RFQ to basically say a request for qualifications to say, hey, tell us how qualified you are to build these types of facilities based on the criteria that we're looking for in this specific type of facility. And we've heard a lot of feedback as to what Whatcom County is looking for in this type of facility, right? Especially the behavioral care elements, the reduction in recidivism, the different type of operations that everybody's looking for in this type of facility. So those are the qualifications that we're looking for in this type of facility. After we shortlist those folks, we'll ask for a management plan to say, okay, now how are you going to build this facility? How are you going to design this facility? How are you going to overcome some of the challenges that we see for doing that? And so ask for those plans. The last little box that you see there is for the interviews. Those are really interactive meetings, and those are a chance for those folks to inform that plan. So it's really their meeting. It's not really an interview. It's their meeting to run, to inform those management plans, and for us to see how they interact, and also a chance to see how well they listen. I've been in those situations before where, we have the interactive meetings, then we get the management plan, and it's very clear that they did not listen. And so that's a big red flag, and those are the types of people you don't want to work with, right? So that's a good way to weed out people that don't listen well. We can go to the next slide, I think, too.
Sure, and I'll come back and touch on it. I'm sure many of you will have questions more about the communication plan and how we'll be interacting. And so I'll come back and touch on the communications plan after we finish the schedule.
Okay. So by July, we should have an intent to award after everything is scored to that design build team. At the same time, we should have the jail capacity analysis complete, as well as the behavioral healthcare analysis complete. That's going to include things like Medicare and or Medicaid funding analysis to figure out. We have a team of experts that are working on that to figure out, okay, given the operational model, what Medicare and Medicaid funding might be available, and or how do we design a facility so that we can maximize those operational funds that might be available, and take that into consideration. And we want to have those reports available so that once we get the design builder on board in August, those reports are ready to hand over to that design builder. And as soon as that way, we can start design with them with those reports to inform that design day one. And then from August on through the rest of this year, it's really that big box on the bottom. A lot of that for the design phase is really this programming phase. And that's it's really a great feature of the progressive design build model is that you have the contractor there, you have the design team there, and you have, the project team there. We can bring in different subcontractors that we need to, and really go through a lot of the different cost modeling exercises that we want to figure in different operational costs during that phase to figure out how big of a facility this is going to be, the different operational models and how things are going to cost, and what this facility is going to look like, with everybody at the table and the right people at the table, so that we can get a general model and then go start to design it, before we design a facility and realize, oh, we can't afford that. So everybody's at the table at the right moment to do that in that programming phase. As you can see, there's a lot of stakeholder meetings that we're going to have, and we've already planned to engage with you folks again after we get the design builder on board. That's why we have the IPRTF engagement there, and then probably again in October. We're planning just to come back to your regularly scheduled meetings so that we can just fit right in with what you already have scheduled. And then we expect that programming validation phase to last into Q1 of next year. And our goal with that is to come out of that exercise with a number of options. Our goal is not to have, here's what you're going to get. It's going to have 3 or 4 different options. So here's a X number of bed facility with this operational model and about this many square feet. And like 3 or 4 versions of that, with a schedule and budget attached to each one of those. So then the IPRTF and the FAB and council and exec, everybody's getting that information to then make a decision around what this facility is going to be before we get into the weeds of the design and construction. But we also need to realize that once we come out of that exercise, that's still a really high level estimate. It's not a guarantee. It's still pretty schematic in nature, but we'll have an operational model and a pretty good idea of what that's going to look like when we come out of that phase. That's all I had. Ashley, if you want to talk a little bit more about the communications plan, maybe.
No, I will.
Or-
I see a couple of questions though. I want to
Okay.
make sure that if there's any, I see a couple of raised hands.
Arlene?
Yeah.
Arlene, go ahead.
Yes, can you hear me now?
Yes,
Yes, we can.
I wanted to talk about communications with the public, which you're going to talk about. So you may repeat what I am saying, but we here are speaking jargon, social service jargon. We talk in a way that everyone understands us, but this language does not apply to the public. They don't hear it. They don't take it in.
Absolutely.
Yeah. So it's vital to train your staff also in speaking a very simple, clear language that the public uses and understands when we're talking to the public. I can't emphasize this enough because it's so important. Yeah, well, you understand me.
No, absolutely. I mean, we find that in all of our professions. I mean, even as we say here, RFQ, SOQ, all of those things, we have to translate those to multiple people as well. So we know we totally understand that. So I'll tell you a little bit more about the communications plan and kind of where we are and what the goals are. So we have spoken with, there's multiple groups. When I think about the different, I think about this almost as like a wheel with spokes, right? In the center of that is the executive, but then around that is Council, FAB, IPRTF, JPOP is a part of that, Sheriff's Office, Behavioral Health, Finance. There's many groups that we're dealing with, and how they all will need to receive information. And so we see ourselves as translators to all of those groups, because even within those groups, they speak a different language, right? Finance team has a totally different language than the Sheriff's Office, than Behavioral Health, et cetera. So we have spoken with all of those groups. What we're starting to do, so we have meetings to basically establish expectations. What do those groups need in order to be well informed, make decisions. How often do they need? What's the cadence of information that they need? And so with those expectations, we are now starting to develop charters. So what are our obligations to each of those groups? And then what are those groups responsible for doing? And in that, and what, and in terms of communication, both between, you know, internal communication, but also out to the community, especially with this group, and how we see IPRTF as really a conduit to the community. And so from those charters, we're going to develop a series of ongoing practices that we will modify throughout the life of the project as we see things are working really well, or maybe we see opportunities for improvement. And even in different phases of the project, right now, we're just getting to know, you know, what is the program? And then we'll be in design. That's a different series of questions that we'll have. And then once we're in construction, then we're dealing with the community in a different way. It's not just community involvement, but it's literally people who live next door that we will need to be talking to on a regular basis. So even when we say a word like community, there's the community at large, there's the community that's directly adjacent, there's just people who might not even be physically in this community, but are just interested parties who might live even in different counties at this point, but they knew about this project and were involved and still want to know what's going on. So we are working on that plan right now, which is why it takes, you know, we started in February with all these meetings, and we'll get to the end of this in May. And so we have kind of tapped into how we will communicate with each of those groups. And with this group, you already have a lot of meetings, you already have a lot of committees and subcommittees. And so we just want to tap into those things. We want to go where the people already are. We don't want to set up a new series of engagements that you'll have to take more time on. So, and so we plan to kind of meet with you quarterly when there are if movement on the project is moving faster than that, then we will meet more often. But I think that what we talked to at a high level, we talked to Peter and Heather and Councilmember Buchanan, was that we can give monthly summaries to let everybody know what's happening at a more regular cadence. There will be a dashboard that anyone can look at anytime, but then we will come and actually speak to you and answer questions. We feel like right now that can probably be quarterly, but when things are happening, it might have to be more often. And so that's where we're headed right now. But we want you to have the information that is important to you in real time, without inundating email inboxes or, you know, cumbersome newsletters, things like that. We want to make sure that you can tap into it when you need to, but that will come to you and answer questions when you need to. And getting back to your jargon question, all of that, you know, when we're speaking in this meeting, we will speak very differently than we will like on that. And even the level of dashboard, there's going to be a dashboard that some people have access to. They're like the finance team, for instance, is going to have every nickel and every penny, and it's going to have information on there, different buckets of funding that that they will be interested in. But the outward facing community dashboard is really just about progress, major milestones, you know, decisions that have been made, how they can interact, and how they can give us feedback as well. And so, yes, absolutely aware of the jargon. We fight with that all the time because every client has their own level of jargon that kind of always tapping into. So totally understood. And so with that, that is the end of the presentation in terms of just the schedule. Feel free to ask us any questions you have. We're happy to be here.
And we will need to move on shortly. So if there is somebody with a burning question, please raise your hand. Not seeing any, I want to thank Adam and Ashley. Feel very confident in your capable hands, and looking forward to our ongoing relationship and seeing this very important facility built. And so thank you so much.
Yep,
all right,
thanks very much.
let's move on. Kayla, why don't you give your presentation, and then we'll move on to Heather. So you
Great.
go ahead.
Thanks, Peter, and thanks, Ashley and Adam, for being here. You know, most of our work over the last quarter out of our office has really been focused on working with STV to align the next steps for the capital project for the Jail and Behavioral Care Center. The response division, as always, continues their good work on some of the other justice project implementation plan priorities. So Hannah, Melora, if you have anything to add, please go ahead and chime in. I do know that some of the data work has been advancing in coordination with Village Reach. So we are really excited to start having a few of those deliverables in. And I know those conversations are happening with JPOP and the index committee. So if folks have questions about that, I'm happy to take those back to the team. On the 23-hour crisis relief center, I'm just referencing my written report if anyone is wondering what I'm looking at here. Nothing has really changed in terms of where we are at from a month or two ago. We continue to be in a state of limbo, ready to go from the standpoint of our own capital project, but really facing a lot of uncertainty at the state level around operational funding for these facilities. Our team was in Olympia a few weeks ago speaking with legislators around this, and it was a very mixed bag. Some legislators were saying, hey, we're still working on a fix. We might have something short-term this session to help a few facilities, or maybe a structural fix that will help us solve part of the problem, but it's going to, take us a year or two to have a long-term fix in place. Other legislators we spoke to were much more pessimistic and really concerned that this is never going to be a viable operational model in Washington, and that we should cut our losses and consider building a different type of facility. So it's a mixed bag. We're waiting to see what happens at the end of this session, and also waiting to see how things are going for some of the other facilities that are a little further along than ours. In the time being, we're working with the Response Systems Division and Peace Health around maybe doing a round of community engagement with this group and others, leaders in the behavioral health field, to make sure we are scoping the services at the facility appropriately, right? Like, are we just talking about a crisis relief center observation unit? Are we talking about on-site pharmacy? Are we talking about behavioral health urgent care, and sort of answering some of those questions around what other services are going to be at this facility? And then ultimately, once this question of operational funding is resolved or not resolved, maybe are facing a decision point about should we build a different type of facility if this isn't going to work out, and would want to work with the IPRTF and the county council on that decision making. So that's where we stand on the crisis relief center. On the sort of negative front, I think folks were aware that we applied for a very large $7 million grant from Disability Rights Washington, and we're a finalist. At the last minute, we were not funded because the projects we were proposing were not ready to proceed. These were supportive housing projects, but we have been encouraged that Disability Rights Washington is releasing another RFP this year. They think we will be very competitive once we're further along in the projects, and so we plan to reapply for that funding. Lastly, just a little bit also on the pessimistic front, just continuing to watch sort of threats to Medicaid at the federal level, and seeing what that means for Medicaid waiver for the jail, and possibly for the behavioral care center as well. I don't have much to add beyond what Ashley and Adam offered on the jail and behavioral care center project, but I'm also happy to answer questions about timeline and our next deliverables on that.
Great. Any questions for Kayla? Any questions for Kayla? Kayla, thank you so much for that report. There is so much there that is pessimistic, as you put it, funding at risk, questions about 23-hour, how the other facilities are that have been built and are not progressing as far as operations go. So many questions about that, what's going to happen in the session. But I really appreciate your reporting to us, and look forward to hearing more in the future. Holly, did you have a question?
Yeah, that was I just want to say that was great, Kayla. Thank you very much. It was really helpful to hear all that. Thanks.
Hannah or Melora, did you have anything you wanted to add to my report or call out? No optimism to share?
Just wait and see what happens with session.
Marty, I see you've got a question.
I've just been wondering, is there a timeline by which the funding that has already been received for the 23-hour crisis relief center facility building has to be spent? Or is it okay to just sit on it indefinitely?
We have a little while. We have, I think, till the mid 2027 is, Hannah, is that right? Yeah, mid 2027. So we've got and like beyond that, that's sort of what we get kind of automatically. Beyond that, we would sort of have to lobby to get it extended. So I would say like we should see what happens this session and then spend some time regrouping and really have a serious conversation before next session. We need to know going into the 2026 legislative session whether we're asking the legislature to continue to work on fixing this problem or whether we're going to focus our energy on sort of a capital budget amendment to allow us to spend this money on a different type of behavioral health facility.
Thanks.
Very good. Thank you so much. Really appreciate it. And you have a report that you'll be circulating, is my understanding.
I sent it, yes.
Okay, great. Okay, very good. All right. So, Heather, you want to go ahead?
Yes, thanks, Peter. Hi, everybody. Heather here. I included, thank you, Jill, for sending out a little handout that I put together. I wanted to just start by saying I think that there's been increasing acknowledgement of the different factors that have been changing regarding revenue and cost of goods and just the variables that we need to be thinking about as we move into actually getting to build a jail that have changed since the sales tax revenue was approved in 2023. So the IPRTF obviously has a role in different conversations, and so I'll just walk through this handout. For today, I really just wanted to take a few minutes to introduce a potential process. I don't think we have time to have a robust discussion, but I want to give you some things to think about and preview what we will be talking about in coming IPRTF meetings. So these are not the be-all end-all questions. I just was putting a proposal together for what kinds of things the IPRTF could discuss. So things like what principles should guide the county and cities as we potentially make trade-offs moving forward in the planning for the Justice Project. What might consequences be if public feels like trust is broken in any of the different commitments that we made during the campaign, and how can we avoid that and incorporate community engagement even if plans change. We included a couple of really good reports that were shared with the Finance Advisory Board for deeper reading. The first update includes some updated cost assumptions, and it is a nice summary of the different changes that the county is considering and different scenarios of that they're already thinking about for financing. And who makes the final decisions? Just as a reminder, the Whatcom County Council ultimately votes on major financial decisions, contracts, and bond issuance. The county executive will lead negotiations with the cities, and the cities have to approve and sign on to the cost sharing terms. So they're not obligated to participate beyond what's in the agreement. And functionally, the Finance and Facility Advisory Board advises on financial feasibility, but the IPRTF can issue motions or recommendations that elevate values, preferred outcomes, or requests for more public process. On the second page of this handout, there's a table that I thought was helpful that shows how IPRTF, JPOP, the Justice Project Oversight and Planning Committee, and FAB, the Finance and Facility Advisory Board, all work together for the greater goals, and what different kinds of conversations and questions each body can consider so that the discussions are coordinated and complementary and not duplicative, and that each committee is really diving into the scope and expertise of that table. So for the Incarceration Prevention and Reduction Task Force, we could consider that the values and vision piece of the entire system, and our primary role is being a strategic advisory body focused on reducing incarceration through system reform. And key contributions to some of these conversations could be setting some values-based priorities and elevating recommendations to the county council and the executive. And so potential questions for us regarding scenarios could be, what principles should guide any trade-offs and what is most important to protect? Again, not an exclusive list, but just something to get us started. So for today, I wanted to just preview and let people know that we would like to have some organized, facilitated conversations that really help us understand what are the different financial scenarios moving forward and how do we continue to achieve our goals given the different limitations, and what options might we recommend and support the county in moving forward. So that's all for today. And if there's any questions about that conversation or anything you want to add about what you want to make sure we start to talk about in the coming months, that would be great.
All right, thank you so much, Heather. Really appreciate that. We're really running short of time, and so Arlene, I wonder if you might be able to direct your question to Heather just via email on that process. We'll have time in the near future to regard those. So, okay, on to the next item, which is Holly and Marty. Did you want to share the calendar and priorities just briefly before we go on to committee reports?
Holly may have a different thought about it, but I think that, the question of, do you want to have an August recess, we already addressed. Okay. And the rest of it is for you all to just have as a guide. And it is a living document. We will be changing it all the time. And for example, Heather just brought up a topic for future conversations, and we can build those into the calendar.
Great. And are the 2 or 3 upcoming review cycles with STV already on our schedule that they showed us today?
What we had was we were thinking about public opportunities for public forums for stakeholder and community engagement. And we had planned for those, but just double checking here. No, I think I was wondering, as they were talking about whether we should have STV and Kayla's quarterly reports be on a similar schedule, and then we can add in additional times if Ashley and Adam feel like they would have something they really want to talk to the group about. We can add them in at additional times. But
great.
Does that sound all right?
Yeah, that sounds great. We can go over that in steering. All right. Well, very good. Thank you very much for that. And let's move on to committee reports. And we have, let's see. We got 18 minutes and we need to fit public comment in. So just keeping that in mind, Bertie, would you like to report on index?
Okay, Index Committee met this month and the minutes are attached in your packet. I think the most important outcome of the meeting was that we had an updated presentation from Julia Garrett, who is our Village Reach consultant. And in that, she outlined the 4 major outcome measures that she is recommending for the implementation plan. And we had a short discussion of how we might define those. They will be disaggregated, meaning that we will have separate reports on the total outcomes divided by those individuals affected by behavioral health and those affected by substance abuse, and then secondly divided by race and ethnicity. So those discussions will be ongoing. the one thing I would point out for the entire IPRTF is that inevitably there will be a discrepancy between what we would like to be able to measure and how we would like to be able to define some of those terms with what we can actually measure and report on with the current state of our IT systems throughout the county. So keep in mind that this will not be a complete package. It will instead be, this is what we can do now, and this is where we see we need to go. And with that, I think that summarizes the gist of our meeting. If anyone has questions, I'm happy to answer them. And again, the minutes are in our packet. Thank you.
Thank you, Bertie. Appreciate that. Raylene, would you like to report now on legal injustice?
Thank you. So we met on April 8th, and Bertie did give us some information on Village Reach presentation and index committee. So she just basically kind of did a summary on that for us. So that was very helpful. We talked about the Justice Project implementation plan. And the different goals that we wanted to achieve moving forward based on graphs that were provided. I think we've got a good jump on the project. We did talk about the LINK program and wanted more information on that, as well as getting more of an update on the True Blood grant moving forward on that. The rest of the minutes are in your packets on page 60 and 61. I think we're still waiting on the State Bar Association's approval, and American Bar Association approval on public defense standards has not been decided on by the Supreme Court, which is the ultimate authority. That was the other touch that we had on that, and that could definitely impact the legal injustice system. Is there any questions on legal injustice? Thank you.
All right. Thank you, Raylene. Next up is steering committee. Barry, do you have anything of import you'd like to speak to?
Just briefly, Peter, we have covered most everything that steering talked about. We did cover that during our meeting just now. One thing that we did talk about, though, that we haven't talked about is communications. And I think Jill did a great job with Jenna in our office researching different ways for us to communicate to the public. And I'll just read this list that came up so far, just kind of in discussion. Posting meeting clips to social media, introducing and highlighting individual IPTRF and committee members, sharing social media with community partners, asking task force members to share their accomplishments, kind of a government 101 educational clips that kind of explain how the task force works and just kind of the mechanics and its purpose. And then just give more visibility to the sequential intercept model, which has driven so much of our work. So those are some of the things that Jill and Jenna brainstormed and the steering committee talked about. So if you have any ideas, please feel free to ship that off to Jill and we can add that to the list. So
great, thanks, Barry.
That's all I got.
There was a lot of really good energy in our steering committee meeting when Jill and Jenna came forward with those ideas, and we really like the idea of executing on those. So
yeah,
thank you so much. Dan, would you like to report on behavioral health committee?
Sure. Yeah, we met on April 15th. We had a number of items on our agenda. Brian Estes presented on the impacts on Medicaid. We were talking about the state level Medicaid that could impact programs that could be downsized or closed entirely, and those remaining could be overwhelmed. We had, I think one of the main things that my takeaway at least was our work groups are now kicking into the work that they're doing. And so we have 3 of them. One is the data work group. I won't, a lot of this has already been covered by Bertie today with Village Reach, and Dean White was also heading that one up. He's the convener. on that one. So we're really kind of digging into the data component of it. Brian Estes is heading up the diversion / reentry work group, and they have their first meeting scheduled for, I think, this week. And I'm heading up the Division Street work group, and that'll meet in May, early May. And that one's just basically trying to figure out some of the things that Kayla had brought up today. You know, what happens if if the funding isn't there for the 23-hour facility and such. We also talked about Tori Sandos from Whatcom Community College. She heads up the SUD, the Substance Use Disorder Professional Program, and she covered the workforce and education issues. We had talked about the outreach for Dijwalik mobile medical units, and then they need more patients. And so I urge folks on this call, if you're in a position to if you're in touch with patients or providers that are, to reach out to me, and I'll get you connected with mobile medical units. Mike Hilly presented on monthly overdose stats. We're at 3.6 ODs per day, 80 to 90 per month. And this is the last 30 days, so it's pretty recent data. And I think that's it. So I'll turn it back.
All right, thanks so much, Dan. Speaking of work groups, I will mention that the Behavioral Care Center work group will be having its first meeting in early May, and we'll be reporting back to you. And last, we have J-Pop. Who would like to speak to what happened in J-Pop?
Hi, this is Holly. I'll do J-Pop.
Great.
So this was our first meeting in person. Our co-chairs, Tasha Thompson and Hannah Sloan, had been very keen on us meeting in person, and it was really fun to get to actually see people we hadn't seen before in the flesh. So we had an excellent presentation from the FAB, Finance Facility Advisory Board. So Barry, Heather, and Jack Hovenier. And that was a big question for the J-Pop, is who is the FAB? And there was definitely interest in having that happen again and having reports from the FAB be part of the J-Pop's regular process. So that was great to get to hear from them. We got to hear the owner's rep. So a similar presentation to what we heard today for the J-Pop members. And then we had more time with Julia of Village Reach, just getting an update from her. And she's done an awesome job of just representing where we are, keeping us, on track. And also we spent some time looking at what the successes of the J-Pop are in particular, since the J-Pop is one of the 15 projects. So that was, and then of course, we're still getting feedback on the IPRTF annual report. So it was a great meeting. Thanks for everybody here who also was there. It was really fun.
Thank you so much, Holly. Appreciate that. I'm going to switch the order of public comment and other business. I want to make sure we get public comment in. If there's anybody who would like to speak, Jill, there's nobody in the conference room with me. And I see one attendee who might want to speak.
Thank you. We do have two attendees, actually. If either of you would like to speak to the task force, please virtually raise your hand now. And no hands are raised.
Okay. Is there other business that anyone would like to bring up? Marty.
Hi, I just wanted to follow up on one thing Holly just said, which is that we are working on the IPRTF's annual report. And this time it's going to have two parts. There will be the usual annual report, which will be about the IPRTF's activities. And then there will also be a section that is a progress report on the implementation plan. And we're going to give you all a draft to review. It's going to go through the steering committee first, then it will come to you. And then you'll get to have feedback on that draft. And then the process is to have a final version for approval in June.
Great, thank you so much. Any other business? Okay, seeing none, just wanted to say, just generally, these are stressful times for all of us here who are on the screen in this meeting. I want to encourage everyone to reach out to each other for support. And I really want to thank each of you for the work that you're doing in our community. It is often not fully appreciated verbally and otherwise, but I do appreciate it. I think we all do. And so thank you all for all that great work. And with that, we'll conclude the meeting and we will see you in the community.